So this is, will chemotherapy no longer be used? And it's supposed to be no. So if you take the double negative, it's chemotherapy will continue to be used in newly diagnosed patients. So being a big fan of chemotherapy, I was very eager to come up and defend this point. So I thank you, John. And I must say, you know, with all the exciting things that are going on, it's easy to see a day perhaps maybe that chemotherapy may no longer be used. So to do my task correctly, I had to do my homework. And so I looked up in Merriam-Webster's dictionary. And I found the word chemotherapy. It's a noun. And it's the use of a chemical agent in the treatment or control of a disease, as cancer or a mental illness. So you have take your pick here. And so obviously we know what chemotherapy is. It's bad. And we have examples of chemotherapy, such as this drug here, bendamustine, which is approved for treatment of CLL. And you can see it's a chemical agent. And we have a number of these. Another chemical agent that's used in the treatment of cancer, similar in some regards, of course, is ibrutinib. So I'm confused. This is non-chemotherapy, but it seems that we may have to change the definition in the dictionary. But by strict definition, ibrutinib is a chemotherapy. But I understand this is not the purpose here. You want me to come and defend such bad players as alkylating agents and the most notorious one, FCR. And this is a therapy that was pioneered by Michael Keating. And they have the longest experience with this, and it was confirmed by the German CLL-8 study that it's actually a pretty good treatment, particularly for young, fit individuals, and even elderly patients who have a very good biologic fitness. And we're all familiar with the scheme here. Now, Bill Weirda has made a mention of this with regard to the study, and John alluded to it just in the past talk. And also, we had an earlier discussion with Federico mentioning this as well. But the idea is this trial was between July of 1999 and January of 2004, which means that we have 10 years of follow-up, which is quite nice. It's the most mature data for FCR. And we had the privilege of doing the mutation status with the folks at MD Anderson. This was done there. And there was no FISH at the time because it wasn't as commonly done. MD Anderson, you know, has a very good response. And typically, the response rates that they have had and are quite respectable with complete remissions in 72% of patients. And so this was actually quite well tolerated. Of course, the patients were younger. The median age was 56. And so therefore, these are younger patients. But what they noticed is that, you know, the patients can continue to do well over this past 10 years, and you're beginning to see the curves even out. And this was mentioned earlier. And so if you look at this, you have the progression-free survival going out over 6.5 years, and the overall survival over 11 years. And I think that what we have is the study can be described that if you respond well, you do well. So good patients do well. And those who achieve a complete response actually have a longer duration of progression-free survival. And this was actually broken down as the various characteristics, and Bill had done this, and what was most notable is the mutation status of the antibody genes. It kind of stands out. And the reason it does, it doesn't seem to affect the response rates per se, but it does seem to affect the progression-free survival after therapy, particularly those patients who achieve a complete remission. And so you could see that 60% have a progression-free survival that has not been reached after over 9 years of observation. And this is true also for survival. So you have a 70% overall survival after that period of time. And they also are keen to look at the beta-2 microglobulin level, and if it's very high, of course, that does portend problems, but then less than 4, actually the patients did fairly well. And so even without the mutation status, it could balkanize patients into good risk and low risk and poor risk patients, so that the higher beta-2 microglobulin subset had a worse progression-free survival. and that's also true for overall survival. So if you don't do mutation status and you have access to beta-2 microglobulin, that does seem to help. So as far as first-line FCR, it stacks up pretty well, and durable remissions seem to be possible, and there are subgroups that have favorable outcome. The patients that have CLLs that express mutated antibody genes, 60% progression-free survival at 9 years, and it seems to be a plateau. And the beta-2 microglobulin subset, if you're less than 4 milligrams per liter, then a 45% progression-free survival at 9 years. So I guess to debate this question, when will we no longer use chemotherapy to treat patients with CLL? And before you answer this question, you have to take this into account. The long-term disease-free remission possible in subgroups of patients who achieve CR with FCR. You have to also consider the advent of newer therapies, the new anti-CD20 monoclonal antibodies. In the CLL11 study showed that a fairly low dose of chlorambucil combined with obinutuzumab could give a 17% MRD negative CR in the marrow, and the question is whether those patients may again achieve a long progression-free survival. There's also data that was discussed earlier today by Dr. Brown. We were able to be involved with the obinutuzumab bendamustine with very high response rates using less aggressive forms of chemotherapy. Now, we also have to consider that even these newer agents are being considered in combination with what might formerly be considered chemotherapy. We have to bring into concern the cost of long-term maintenance therapy, and as John alluded to, over 100,000 per year. A patient with mutated antibody genes who is treated successfully with FCR, 10-year progression-free survival without evidence of disease, would have spent over $1 million in therapy after that period of time. And then you also have to think about the treatment of patients in countries other than the US. And this is clear because there seems to be a greater adherence to recommended guidelines in some other countries, and including the third world. You know, I think if you have the third world, some of these agents are not going to be attractive. And perhaps when they become generic drugs, they may be used more frequently. And the real question then should be, when will oncologists stop giving chemotherapy to patients with CLL? I guess it might happen eventually, but I think not likely soon. So, thank you, John.